Entrance music. Rocky.
Yeah. All right, folks, good morning. We've got limited time and lots to discuss, so we might get underway. By way of introduction, I'm Mark Scott. I know some, but not all in the room, and I think we'll go around and do introductions in a minute. I'm Vice Chancellor here at the University of Sydney, and the University of Sydney is delighted to host this symposium for Australians for mental health. Can I begin by acknowledging traditional owners on the land in which we meet? We're on the land of the Gadigal people here of your nation. We often reflect on the fact that this is Australia's oldest university, and we keep reinforcing that to the University of Melbourne, who just jumped. I know you are. We're very, very glad you're here. But Australia's oldest university, we've been going for 170 years. We think that's a long time as we close in on 2 centuries. But then we reflect that traditional owners, First Nations people, have been teaching, learning, discovering, sharing knowledge here for hundreds of centuries, and we're trying to build this university on that lived experience of First Nations people, and we want to pay our respects to our elders past and present. I've known Chris Rain for a long time, and given he's a young man, it's remarkable. I must have met him when he was a very, very young man, but and there are a number of others in the room that I've met and worked with in different guises over the years. But this was felt to be a great opportunity just to bring people together and think through the opportunities that I think exist at the moment now, to think through what propositions are, or is there a core proposition that needs to be placed before a government that is ambitious, a government that has a significant mandate, a government that wants to bring about substantive change, and what would we suggest and advocate to them as far as key propositions for improving mental health in Australia and improving the infrastructure that supports mental health in Australia. And one of the feelings I've had over the years in working in different kind of public-facing institutions is that governments want solutions to the challenges that they face. And if in fact you are just there with a lot of needs and your cap out, then fine, but it's a long queue, a lot of people, a lot of powerful voices out with the cap out. Governments are after people who bring solutions to the challenges that they have. And so I think the feeling was, could we gather together, and was there a meaningful opportunity to have a symposium where we could discuss, would there be a clear, consistent, compelling question and proposition that we could agree around, to think about how you could frame and build that up as a proposition to government, thinking particularly for the 2024 budget, and then opportunities in the subsequent budget and the lead up to the next federal election. So that's what I think the shape of the day looks like. But I appreciate everyone doesn't know everyone. So as we get started, I thought it might just be good for just everyone to introduce themselves. Now, if you're in the room here, assuming this technology works, just need to turn on the microphone as you speak, so particularly the folks on the Zoom can hear us. So we'll go around the room here, then we'll go around the Zoom, and then we'll get on with the challenge of the day. So Chris, we'll start with.
Well, thank you very much, Mark. So I'm the CEO of Australians for Mental Health, and here, I guess, helping coordinate the day.
I'm SJ, also from.
Pat McGorry, I'm a director of Australians for Mental Health, and my day job's executive director of Origin and professor of youth mental health at the University of Melbourne.
University of Sydney.
Hi, I'm Lou, and I'm from Australians for Mental Health. I'm after all that operation stuff.
Hi, I'm Angelo Bagona. I'm the chair of the College of Psychiatrists in New South Wales, and I invited myself to this meeting.
Good to have you.
Hi, everyone. I'm Marie Thiessen. I'm a professor here at the University of Sydney, and I direct the Matilda Centre, which is a research centre here.
Hi everyone, I'm Priscilla Bryce. I am the CEO of Being Mental Health Consumers, which is the peak body for mental health consumers in New South Wales.
Hi everybody, my name is Sebastian Rosenberg. I'm a senior lecturer at the Brain and Mind Centre at the University of Sydney. I head the policy stream of the Brain and Mind Centre.
So I'm Ian Hickey, I'm the co-director of Health Services at the Brain and Mind Centre.
Hi, my name is Alison McLean. I'm from AAA Australia, where I lead all their clinical health and wellbeing programs.
Hi everyone, my name is Lisa Sweeney. I'm a director from Australians for Mental Health, and my day jobs I work with Pat at Origin in advocacy and engagement, and I also do some work in the Victorian Royal Commission implementations.
Hey everyone, John Meyer, also Director and Chair with Australians for Mental Health. My day job is also with Origin in the Origin Digital Technology Division. So very happy to have such a great group gathered, and thanks again, Mark, for hosting us today.
Great, thanks. And we'll go quickly around the Zoom screen as well. Dee, you're in our top left-hand corner, so we're going to start with you. And then...
Dee Madigan, I am on board of Australians for Mental Health, and I run an ad agency dealing in the progressive space.
Great. We'll just let others dive in rather than call you in around the screen.
Hi, I'm David Perkins. I have an adjunct chair at the University of Canberra and a conjoint chair at the University of Newcastle, and my obsession is rural and remote mental health and suicide prevention.
Yeah.
Hi there, my name is Colin Tate. I'm here, I'm an entrepreneur in life and a philanthropist, but I'm here today with lived experience in mental health and addiction over many decades, dialing in from my farm in the southern Tablelands. I'm a friend of Chris Rain and appreciate the work Australians for Mental Health are involved with. And I'm also on the board of Neuroscience Research Australia, NEURA, and chair of the foundation at the University of New South Wales. Thank you.
I'll jump in. Simon Judkins. I'm a ED director, emergency physician, ED director up in Echuca Health, so rural emergency department, and chair of the Australasian College for Emergency Medicine's Mental Health Committee. I'm here representing ASIM, yes, College for Emergency Medicine.
Thanks, Simon.
I'm Karen Henderson. I'm from the Mental Health Coordinating Council in New South Wales. I'm Principal Policy Advisor at MHCC. I also sit on the Mental Health Review Tribunal in New South Wales. And thanks for hosting the day. Good morning.
I'm Danny Rock. I'm from the Bear Primary Health Alliance. I'm a clinical epidemiologist and a clinical professor of psychiatry at UWA.
G'day, I'm Andrew Pryor. So I'm board director of a couple of organisations, including Flourish Australia and MHCN. I'm also involved with the National Mental Health Care and Consumer Forum.
Go
ahead, Caroline.
Caroline Cross from Wise Employment from the Innovation and Mental Health team.
Bill Campos, CEO of Independent Community Living Australia. We do a lot of work with people with psychosocial stability. I'm also a person with a lived experience, a family member, but importantly also working with Digital Health Agency as a consultant, as well as the New South Wales Mental Health Commission.
Hello, I'm Bill Guy. I'm the CEO of Community Mental Health Australia, which is the national body of for the coalition for all the state peak mental health and territory organisations. And just an apology, I can only be here for the first hour today as well too, but thanks for the opportunity.
All right. Oh, hi. I just wanted to, last one. I'm Frank Iafino, Senior Research Fellow at the Brain and Mind Centre. I'm in the lecture room with other researchers from the Brain and Mind Centre and part of the Youth Mental Health and Technology team.
Sorry, and lastly,
Kim
Rosie from the Corporate Mental Health Alliance, representing 28 large corporates with an employee base of around 500,000 employees.
Okay, well, thanks. As you can see, a fabulous representative group, you know, great diversity, great policy perspective and experience in the room. And in a way, it strikes me as the outsider coming into this conversation, thereby represents the complexity and the challenge. You know, everyone's working in different areas. And what I'm sure is the case is that in all different areas where you're working and focused, there's overwhelming need, a sense of chronic funding shortage, lack of long-term strategic planning and initiative to bring a step change in solutions that people are looking for. And I think in my experience working closely with government as a department secretary and my time running the ABC, just spent so much time in those corridors in Canberra. You know, what you do get a sense of is the door constantly being knocked on with someone else who has in isolation their own compelling idea of something that needs to be fixed. Almost impossible for government to kind of deal with that wide, disparate array of need. And so often it's who's got the loudest voice, who's got the strongest advocate, who has a media kind of juggernaut that comes in behind them. And finally, it's this very kind of short-term, pragmatic decision-making process that drives funding solutions. And as I said earlier, I think the idea here is to think through, can we come together and think about how you can focus and concentrate an ask and have a chorus of voices in support around an ask, and then execute a kind of longer term advocacy strategy around what are simple and compelling propositions in order to get government's attention. Some of you would have seen an editorial in the Sydney Morning Herald yesterday that said, well, the Albanese government is making a good start across a range of areas, but one area where it's notably failing to engage and deliver significantly is around mental health. And so I think the time is right to see whether Australians for Mental Health can coalesce around the clarity of a challenge and an ask to government. And so that's what today is an exploration of. We've only got 2 hours today. This problem and challenge has been a long time in the making. Who knows how far we can get today, but you only get there by making a coherent and concentrated start. So we're planning to structure some conversations around that. But Chris, I'll hand it over to you, and then we'll kind of work through some of this. Yeah.
Well, thanks, Mark. Yeah, just to echo that voice. This is probably the hardest job I've ever done so far. So when I started at Australians for Mental Health a little bit over a year ago, we had a kind of organisation. We've done a few things that have been really worthwhile, including influencing the Victorian Royal Commission and kind of growing an organisation. And then the last 12 months, I think the challenge that we've really, the fundamental challenge that we've had is not having a very clear ask to government, a singular ask that actually would be effective in getting investment. And the last federal election was quite tough. And we had lots of meetings, but not really anything concrete that's come through. And part of that challenge, I think, is getting that support. And about a year ago, I was expressing the frustration that I had to Mark, and he was like, we should do a symposium. And it's taken us a year to get this to actually happen. Welcome. And I think there's very disparate views across the room into what needs to happen, but a goal that we perhaps can move towards attaining is to have one thing that at the next federal election we'd want to see. So in talking about the agenda for today, Mark had the great suggestion that perhaps we could have a point of reflection on what it is that the government would be proud of achieving, this current government in the next 10 years. And so we were thinking that we could have a kind of maybe perhaps take a moment to reflect on that, and then go around and share what we think that the government would be most proud of. For example, when I spoke with Christopher Pyne out of office, it was like the thing that we did was Headspace as a point of pride, that we'd love to see that the current government have a similar kind of outcome. So yeah, in the first sort of activity, what we're thinking of doing is perhaps taking a few moments of reflection, and then we go around and share what we think the 10-year vision of what this government should do hopefully we can get a clear idea of what we might be able to achieve.
Yeah, so let me talk briefly about the benefit of looking forward, I suppose, and looking back. In my time running the ABC, just at the beginning of all the digital activity, it was almost impossible to predict where you wanted to be in 10 years' time. You just knew which way the future was going. And the future was heading that way. And so you needed to be in a position yourself where you could take advantage of any opportunities that kind of came at you to kind of further advance your movement in that direction. But I do think 10-year timeframes are useful because you don't have to get every solution sorted out tomorrow. But there are a series of things that if you want to bring about a transformational change in 10 years' time, there's either very important preliminary work that you need to do, or there are some things that are so big and so important that you need to start now if you're really going to see an impact in 10 years' time. And so we thought of framing the question here today in these terms. I think this is a government that wants to do good work. I think many of the politicians I meet, they had plenty of choices in life. They chose to go in politics because they thought that was the point of having greatest leverage and greatest impact over the things that matter most, and impacting on the greatest number of people. And I think many in this cabinet that I've met and that you'll have met line up with that. There is a line, though, that says all political careers end in disappointment. You know, it's hard work. And it's like that line of the former British leader who asked what's the toughest thing in public life, and his answer was events, dear boy, events. You know, the circumstances of life just keep coming at politicians. So it's really very hard for them to get anywhere near as much done as they would have hoped to have got done in their early idealistic stage. And so if they can get to the end of their career and they can point to an event, they can point to a reform, a significant initiative that really had traction, had an impact, worked for them, that can be something they can be very proud of. And so we thought of Mark Butler, who has responsibility for this area now. And we thought an interesting kind of thought exercise for us would be pretend you're Mark Butler and pretend it's 2033. And assume you've had responsibility for this portfolio over a decade. And yes, there have been, you know, recessions, there have been budgetary pressures, there have been global pressures that have come to bear, a whole series of things that you didn't recognise that have been forced on your agenda. But if you got to the end of the decade, what could you look back on and say that you're most proud that you've achieved? What would be a great achievement over a decade for the minister who was responsible for mental health? Just as, you know, other politicians talk about the NDIS or other kind of just significant landmark reforms. So I think that helps frame, in a sense, our ambition for what we think could be possible to achieve over 10 years. And then you can work back from that, saying, well, that's where you really want to get to. Starting where we are today, where do you start? I think in a lot of strategy discussions I've been involved in, there are two great conversations that need to be had. One is where we are today, and the second one is, well, where do we really want to get to? And then often the strategy falls out from those kind of two conversations. So let's frame that question. You know, imagine you're Mark Butler, it's 2033. You're looking back, you've had 10 years in office in this portfolio. What have you achieved that makes you proud? And then can we work through what were the building blocks that got us there? So that's kind of an open question to the room, really. I think we sent that out in advance. Yeah. Oh, so some people have done homework, which is wonderful in an educational setting. So I think what would be great for the next 20 minutes, half an hour, is to hear from an array of voices and to try and map the different ideas and different perspectives that emerge from what a decade of great policy reform got us and led us to over time. So in the grand tradition of education, I'm happy to cold call, you know, but are there people who want to dive in first? Chris?
Yeah, I just want to say to talk make sure you press the button so they can hear you on the Zoom channel. And just also some rules of engagement. We have we have people from insurers, people from lived experience, clinicians, and often there can become quite a singular view of what the system will look like. So we want to have a spirit of yes and, like that this system can be all things to all people in this context. So that's really important, but we want to really have a future vision first and foremost. So I'll open up to the room for any reflections.
We'll lead off first. Yes, Simon, put your hand up there, Simon. You go for that.
Sorry, is that me?
Yes.
I guess, through the emergency department, emergency medicine lens, I think, we're pretty simple folk when it comes to policy and strategy. But look, one of the, I think we've advocated for over the last 10 years now, is the fact that we have a system which, for many, many people, the journey leads to an emergency department, which is inevitably overcrowded and under-resourced. It's not a therapeutic environment for people who need mental health care and intervention. And often, very sadly, the people who end up in emergency departments spend days and days there waiting for, the next step in their sort of care. Often that will be, admission into an inpatient facility. We, sort of started pointing this data out back in 2015, 2016, that we were seeing people spending 3, 4, 5 days in emergency departments and not being able to access the care that they need in those inpatient facilities. So, it's a pretty simple sort of goal, but I'd imagine the Minister would be very happy to say that in 10 years' time that we no longer have patients spending days in emergency departments trying to access care, and that we see that whole that eliminated, because we've got good access to community care. We've around the clock. We've got other facilities that are available for patients and their families, so they don't actually have to resort to coming to emergency departments. And we have enough capacity within the system, so when people need inpatient care, that there is an appropriate, resource available for them. So I think a goal in 10 years' time would be to see no patients, no people, no clients spending, more than, 12 hours in an emergency department waiting for the next step in their care, whether that be, discharge with appropriate community supports or admission into a hospital.
Thanks so much, Simon. If I could just also just express in the brevity of getting to hear from everyone, if we give us a high level, like this is the vision statement, but yeah, people not spending time in emergency care longer than what they need to is perfect. But yeah.
All right. So we've got hands on the screen, but hands in the room too. So we'll go here first. Yeah.
Oh, thanks. I think we're going to start with the blueprint. So if I was Mark Butler, I would have commissioned a blueprint, because without that, we're just going to keep fumbling in the dark as we have done over the last 40 years. And I think the National Mental Health Commission has got the idea of a blueprint sitting somewhere on its website, but there's no actual commitment to it. And it needs solid commitment. And without a blueprint, we're not going to get anywhere. Without sort of a change in the federal state arrangements, we're not going to get anywhere. Without reform of Medicare with respect to mental health items, we're not going to get anywhere. There's so much to do, and they're not going to get anywhere without a blueprint. So I would have done that and taken the steps to implement.
And can I ask, my job's to ask the naive questions. Do they believe they are operating under a blueprint? So when you say no.
No one believes they're operating under a blueprint.
The Federal Health Department think they've got a national mental health policy, but no one else thinks that.
Yeah. Okay. We'll come back to all of these. Thanks, Bill Campos. We'll go to you.
Thanks. I guess from my point of view, there are two things that I think it's important to highlight. I'll start with my background in terms of clinician. I think there needs to be a discussion a little bit about mental illness and a mental health episode or a condition. In my understanding, personal experience, there's discussions about a lot about mental health, but I think we need to start developing a conversation about almost like they do in diabetes, a type 1 and type 2. So we know that with people with mental illness, there's a long-term sort of support that's required for someone with a, very difficult condition. So that's the first point. The second point is more of like an administrative and executive. I think one of the things that often I found frustrated when I worked in PHN is that the money and the service didn't go down to the people that really needed it. I'm a big fan of some regional planning tools. I'm not sure if Ian Hickey is there, but the sort of work that does to highlight and diffuse and get away some of the noise that happens with a lot of advocacy for different joys, to have a tool that allows us to know a little bit about what the flow of need is at a regional level is really important. And then you can bring government departments together to work at it, like I call community hotspots, to really target different areas of need based on those sort of planning tools. I can go on and on and on, but I think there's my 2 points.
Come back to this over here. Yep. Michael. Yep. Good.
I think that they could look back and be proud on developing and implementing a robust planning protocol between state, federal and local governments to ensure that care is delivered seamlessly across the care continuum, and a mechanism for the sharing of clinical information between services and clinicians when concerned with the care of the same individual, should in the days of the internet be possible. And the legal issues need to be resolved by someone in authority and not by clinicians and carers and consumers on an ongoing basis. We need to look at developing robust psychosocial models of care based on our best understanding of mental illness, mental health and recovery. And we need to have those models set up so that pathways of care up and down the level of acuity as required by an individual's needs are facilitated, envisaged, funded appropriately so that each stage of care has enough resources to deal with people who are likely to experience that, and it's a logical size to that pipeline for the next phase of care, up or down. If we could get those things, psychosocial models, robust pathways and planning between the 3 tiers of government, we'd have a basis for a system.
Yeah. Thank you for that. Caroline.
Hello there. If I was Mark Butler in 10 years' time, I would be very proud of not smashing any glass ceilings. He probably doesn't need to do that, but smashing a glass wall, breaking down the divide between employment and health. I know I use this line often, but the last one to discover water will be the fish. Recognizing how important having meaningful engagement is to all of us, 3 simple lines, what we all need: somewhere to live, someone to love, something to do. And it's employment that's the key goal for so many people with mental health conditions, that it would be really good to have more alignment between the mental health sector and the employment sector, more recognition of what assistance needs to be provided to employers to provide responsive workplaces, what assistance needs to be provided to people to build key skills for work, and how we can align two, quite significantly funded departments, but with very different cultures, different vocabularies, different training and expectations of their customers or clients, depending on which sector you're in, which can only be confusing, and we know is confusing. And even with IPS, the outcome rate for people with mental health conditions in terms of not getting but keeping a job are still unacceptably low. So if I was Mark Butler, I would be very happy if there had been some more joined up working, joined up thinking between mental health and employment services.
Thanks, Caroline. Yeah.
Thanks, Mark. This is a really interesting challenge, and my concern, and to the extent that I have any sort of understanding about the system, it really focuses around accountability. And so it's very difficult to answer your question because the systems to permit us to understand do not exist at the moment. whether we're making progress or not. And so the main thing that the federal government could do would be to establish some more robust accountability to be able to tell. So, for example, one of the things that to build on what Carolyn was saying and others, in 10 years' time, more people with mental illness are housed, employed, and living contributing lives. Well, the really interesting thing about that is we don't measure any of those factors, or we rely on pretty poor proxy measures. So we really have to understand, put in place the structures to permit us to understand the impact of what we've done in 10 years. So Mark Butler does not have that now and needs that. Similarly, can we understand the measure of averted burden of disease through effective care? We cannot. Do we measure avoidable hospitalisation in mental health? We do not. So these are key markers of systemic success that are missing. And so particularly in an environment where federal-state responsibilities are split, this is clearly something the federal government can drive, which is the development of better, fairer, more regular, accurate accountability so we can track progress.
Yeah, I've spent a lot of my time in education and the parallels, but the joys and the challenges of federation and split model, split accountability is kind of very, very similar there. Dee, we'll go to you.
Okay, I guess 3 points. One, I think a government that puts in some measures for corporate responsibility on mental health is a good idea and very sellable because it removes the cost of burden a little bit onto that, which I think is important for 2 things, because it actually means companies, if they're responsible for it, might actually be a little bit better at alleviating some of the issues for it. And I think there's other 2 things going on. Caroline's point is increasing, literally just increasing the amount of mental health professionals per population. If we can say in 10 years, there is 1 psychiatrist per 100 people and 4 psychologists, whatever the numbers are, and I don't know them. And also that every hospital built has a mental health facility attached that's not necessarily just acute, but it's where you go for all your mental health things. And it'd be great if that was retrofitted as well. But instead of just a mental health unit for, at that point, the really acute things, that it's just a normal part of a hospital.
Thanks, Dee. We'll come back and look at the staffing question in a minute. Pat, yeah.
Thanks, Mark. Just like to say 2 things. First of all, I think Australians for Mental Health could amplify this idea if people agree with this. I've been very influenced in recent years by the writings of a woman called Marianne Mazzucato, the UCL economist, who's formulated this mission-based approach to reform of big questions. And that means basically trying to get Mark Butler and Jim Chalmers, who both of whom know about this work, to treat mental health as a national mission. And that there are a number of features involved in a mission-based approach, which means that money is not an issue. Money is put aside, like with the moon landing, and in fact, you end up spending a lot less money than you think you're going to spend if you adopt this approach, and a number of other features within the model. So I think that's a possibility with this government, coming back to what Mark said at the beginning. And obviously, my colleagues and I have worked to try to give government solutions, which Chris gave one example, but there's other examples and other examples of what other people have done where the politicians have looked back with significant pride about having made a stepwise change. I think in New South Wales, the Richmond Report back in the 80s with John Holt and Alan Rosen, what they did with community-based care was another example of that. So I think what we've got to aspire to is a little bit more, like not disagreeing with anything that's been said, all those elements fit into this, but a holistic model which is developmentally sensitive to the stage of life. And obviously, I think we should privilege young people here because most of the onsets of mental illness are in young people. That's where the most bang for buck and social progress is going to occur without neglecting any other parts of the lifespan as well. But we've got to have models of care which deal with this missing middle problem, where you can get low-level primary care, dilute stuff, which works for that level of need. You can get acute care, albeit very poor quality a lot of the time. But in the middle, you've got this huge level of need, whatever type of the lifespan it's in. And models of care are half designed, half formulated. They're split between psychosocial, which is done by NGOs, without enough money, and then you've got the clinical services doing this, but that's a very fractured way of providing services. We just saw them on the news this morning, the NDIS being discussed in great detail about how it needs to be completely rethought. Well, that's split off from what we're the biggest cause of disability in Australia in mental illness, and we're a minor part of that. So I think if you talk to Shorten, if you talk to Butler, an integrated approach of the psychosocial and the more clinical sides under one sort of one-stop shop governance, that's possible. That is not rocket science. That can be designed, and I think that might be something not only the whole sector could get behind, but maybe with that sort of high level vision or mission type approach, these ministers might actually be interested in that.
Daniel, we'll go to you.
But I think kind of an elevated view is that we need to have measurably better outcomes at scale. And at scale, I mean, national, regional and sub-regional. We don't have a way of doing that. And by scale, I think the way we think about this is rather archaic. And we have, I've said in a talk, a commonwealth of perpetual pilots. We know we just do stuff over and over and over again, but nothing gets locked in. If you think of PBS as scale up and choosing wisely at scale out, we think we have to choose one or the other. But if you look at, say, somebody mentioned Headspace, that's kind of an interesting example of scale up components, which are the core, and then an adaptable periphery that embeds it into a place. And too often, I think, and this may sound critical, for lots of stuff we're doing is designing chip shops. You design one chip shop, you design one, and then you go to the next and the next and the next, and it's completely unfundable because we don't show, we just keep prosecuting an argument we need to be bigger, but we don't show any kind of clarity around how that would work at scale so that there's measurable benefit. And we have examples, and I think the future is this notion of a digital exoskeleton, a kind of a common core around which accountability structures can be developed. And then those people in Treasury and Finance can have some confidence that their investment is not pouring down into this kind of reticulated filter of money kind of outflows, that who goes where. So I think that notion of a system view that is measurably greater at scale. And then I guess kind of to Pat's point about settling on a fundamental perspective and then working out the instrumental perspectives afterwards. I think we confuse the two often, and then we end up bumping into each other because we're fighting over crumbs. I think having a clear fundamental perspective so that we have a common ground that we're working on, and it may be youth, it may be whatever, but I think it needs that, otherwise we quickly fragment and become disparate voices.
Thanks, Daniel. Yeah. In the room, Sil. Yeah.
Thank you. Frankly, I think some of the ideas I've heard today, some consumers will find quite alarming. And I think as a sector, we need to commit to doing no more harm to people and increasing, their, crisis, I suppose. And actually, personally, I think that the process is more important than putting forward a definitive plan. This is what we want the government to do. I think the process needs to involve consumers at front and centre, and that consumers co-produce the solutions, which then we can put forward to government.
Thanks for that. We're just going to keep drawing out ideas and then we'll see where we get to. I think if you're Mark Butler and you listen to this conversation, you're even more overwhelmed by the challenge. Lots of ideas, lots of perspectives, but how do you kind of put it in a coherent shape and form for him? Bill, we'll go to you.
Yeah, thanks for that, Bill Guy from Community Mental Health Australia. And I certainly agree with everything that's been said so far. And I take the challenge there of how you could pull all those pieces together. So my 10 cents worth on how you could focus these into a particular practical initiative would be to focus on the initiative of filling the enormous gap for effective psychosocial support program outside the NDIS. Now, the reason for this is that there's at least 150,000 Australians currently out there with really significant support needs who are not getting it, who need this. But importantly, there's the political practicality of this proposal. We'd be adding weight and nudging an existing project that has momentum within the implementation of the National Mental Health and Suicide Prevention Agreement. I think it was clause 126, 130 for those that want to check it out. And also, I think what's important is in practice, and I've just come from a bit of a trip looking at a number of new psychosocial facilities that are out there. It's really morphing and changing. And in practice, psychosocial has now morphed into biopsychosocial support with a range of lifestyle supports added in with diet, exercise, etc., that gives it that bio component as well too. So I think it's the design of what this program should consist of is what this group and people with lived experience could add such great value to. If it's designed well, it can be preventative focused, capacity building, outcomes accountable, and built without all the negative incentives that are baked into the NDIS right now. And it also could be the outreach component and building upon the health network that's being established. So finally, I guess while there's some momentum on this particular proposal, it's a little bit like raise the rate. There's not quite enough voices really to push it over the threshold into political reality. So I'd put that forward as one that I think we could draw all those big picture issues and the perspective that Pat just put just then and others into that specific proposal, because it's there on the table in front of us now.
Okay, thanks, Phil. Yeah.
Hello, I'm Lou. I'd like to speak from a lived experience perspective, not from working with Australians for mental health. I'm going to put forward a very lay solution that I would propose is to establish wellbeing centres in all schools. So we're talking about, taking early intervention. My son's high school has brought in this wellbeing room where students can just go, their friends can take them. They get to just sit in a supported space and talk with someone. And there's a whole level in their library which is dedicated to providing children support. So we might not see this as parents at home, but there's a whole level of interaction and where kids are spending most of their time, where people across different, backgrounds, socioeconomic, might not have a supportive family at home, but has an ability to have a face-to-face supportive network with them at all times. So I don't know about the practicality of actually doing that or how you would do that.
Yeah.
However, if we did that, what a change that would make in 10 years' time to kids growing up in terms of changing the stigma, changing the language around mental health, changing the support networks, which as generationally we can see that hasn't been the case in the past. So that's my lay solution.
Yeah, thank you
Please,
for
Mark.
that. And I think it's worth remembering, there's a line from Bill Gates I often liked, that people always overestimate what they can achieve in 1 year, but underestimate what they can achieve in 10. And so if you put a 10-year lens on it to be ambitious about what you want to can achieve, decade is a long time. Eileen, we're going to go to you.
Yep.
Hello, can you hear me?
Yeah.
Thank you. That's good. I'll also speak from a lived experience perspective as both a mental health consumer as well as a family member of other people who have significant mental health concerns, as well as the intersectionality that goes with physical health, disability, and other things that affect life. I would be proud if in 10 years, mental health is not in competition perpetually across the lifespan with all the social determinants of life, the physical determinants, everything. At the moment, it's always dependent on the flavor of the month in state and federal governments as to where mental health is in competition with or having to be piggybacked onto. instead of, as you mentioned earlier, the kind of more national mission kind of expectation that we want a mentally healthy Australia for all Australians. Who's to say that somebody who's not a consumer this hour might not be the next hour? So I think our language and our thinking has to shift away from 20th century models and 20th century thinking and get into the mid part of the 21st century where we are, where we look at a whole person in the whole of their life, in the community where they live, not just perpetually having the competition across the lifespan between clinical and personal and family models. All of the plans, all of the reports, we don't need more of those. We've got them. We know what the problems are. We actually need the solutions, which have been robustly recommended over the years, but not implemented and not long-term funded. Instead, everything is pilot. So I would be very proud if every solution that's planned includes the voice of more than 47% of Australians who come from other cultures. If it's informed by the voice of lived experience with equity, not the token consumer in the room or the token family member, but instead we have more voice and equity across every decision. So there is that transparency and that accountability. Thank you.
Thank you for that. There are plenty of hands up on the screen, so I think we'll whip through those, I think, and then see if there are other voices in the room, and then we'll try and pull together and see. Corinne, we'll go to you.
Thank you. Well, if I was Mark Butler, I would be very pleased if I could see that there was demonstrated evidence that the recommendations of the Productivity Commission report would be, implemented. In other words, that was, I think, recommendation 17, which speaks to the gap that Bill Guy was talking about. That services are really available at the right time, the right place, and that meet consumer goals, and that services are integrated across all human service settings. And services truly support people to live a meaningful life and keep them out of hospital. Thanks.
Thanks, Corinne. Colin, we'll go to you.
Yeah, good morning. Again, thank you, Colin Tate. I really appreciate all the views that have been shared so far. However, I would observe that much of this, at the moment, this conversation is around the acute end of mental health. And given we have data that suggests that 4 out of 5 Australians are experiencing or will experience some kind of mental health concern, that's the majority of the country. So my view would be this. I'd like to underline Mark's opening comments and Chris's. We have a very ambitious Albanese government that are showing all the positive signs right now of being a young and hungry and grounded government. And I think that knowing Chalmers and knowing Mark and others, I think that there is a massive opportunity for this to be forwarded in a way that we haven't seen for many decades. So given that, what would I be proud of if I was a minister and if I was a former mental health minister, no less? I'd want to not only deal with the processes that have all been mentioned so far today and the structures of state and federal collaboration and of the hospital system improving and so on and so forth, and access to psychiatrists, psychologists, all of that stuff. But I'd also want to go kind of much more 30,000 feet and look at what's under the hood for why we have such mental health concerns in society and start to deal with some of those long-term reasons, which is very much getting embedded into the education system, as has been mentioned once already today. It's very much looking at the case of the state of our loneliness within society. It's very much looking at how we reduce domestic violence and other aspects that create long-term mental health concerns through trauma and child trauma and the like. The final comment I'd make is I had the privilege over the weekend to host John Owen, the CEO and pastor of Wayside Chapel, and 11 Indigenous people here on my farm. We had 3 nights sitting around a fire as a white man. I've never done that before with 11 Indigenous people from ages 8 through 60. Every single person had multi-generational trauma that they were sharing around the fire. We were there with a didgeridoo and a couple of guitars and looking at the stars and all that stuff. It was a really magical 3 days, but I was just left overwhelmed by our First Nations people and how undealt with that multi-generational trauma is, and why the statistics are so dire on everything from addiction to life expectancy to presentations with police and presentations at hospitals and so on. The good news to close, the good news is we seemingly also have a government initiating the Voice as committed also to actually solving the data around our Aboriginals and First Nations people in every way. And I think mental health would be one of those areas that if the Albanese government and the mental health minister, the health minister can look back in a decade and say, we've improved the presentations of First Nations Australians dramatically by these data measurements, and we've improved life expectancy, we've reduced violence, we've reduced addiction and so on and so forth, then I think that'd be a very proud story in 10 years' time. I'll pause there. Thank you.
Thanks, Colin. David, we'll go to you.
Thanks. I'm speaking from a rural perspective, and my first comment would be that primary healthcare, general practice, some form of primary healthcare, Aboriginal controlled organisations are in or available to most communities. So what I would like to see would be a situation where the local primary care could provide and coordinate care for people with mental health conditions where they live. And I say deliberately provide and coordinate in the same way that they do for people with cancer and for people with all sorts of other serious conditions. And that Mark Butler could say people in rural and remote settings can access quality care for mental health problems where they live, albeit by different modes of delivery. Thanks.
Thanks, David. Collier, welcome to you. We didn't introduce you at the beginning. Great to you work in that building. You bring expertise and insight. Welcome to you. What insights for us today?
Thank you. And I just wanted to say thank you to everyone for sharing everything that you just have. It is great to be here. I'm sorry I was a little bit late. For the 2 years before I entered the building, I worked in youth mental health services as well, which is why this is an area I'm particularly passionate about. I guess what I would offer is, from a perspective of being in the building and looking out, federal government, I think, can do 3 key things. 1, it can lead, so it can provide the leadership that we need as a nation. 2, it can coordinate across what is a very complicated federated system here politically. And 3, it can provide appropriate stimulus where that is required, whether that is financial stimulus, human capital stimulus, or intellectual property. I would make the point, we've had 53 major reports into mental health across our country with over 9,000 recommendations. So arguably, our country is in the middle of what I've heard others call a plan-demic. We've been planning for years on how to tackle these issues, but we're not making a lot of progress on that. And we're seeing all of our macro trends are becoming worse, not better. So if I was Mark Butler and I was sitting here in 10 years' time looking back, what I would want to know is that I had used my time to actually not reinvent the wheel, that I had harvested everything that had been done to date and identified where those opportunities to actually take action were. I want to reiterate, I really value those comments around measurement. I think without measurement, we are nowhere. If we don't know who needs what, where and when, and then we're not matching our services to those needs, we're failing. And I think ultimately in 10 years' time as the minister, I'd want to be seeing some of our macro trends turning in the opposite direction, so that actually we weren't continuing to power out of control. And that brings me to the point that Pat made. I think there is a real case here for Mark Butler to make a case for mental health to become part of our national mission. And I think the timing is particularly interesting for all of us in this room, and that we also know our Treasurer is currently playing with the idea of a wellbeing budget. Yeah. So if mental health is not at the centre of a wellbeing budget for our country, then what is going to be there? So I guess if I was Mark, I'd want to know that I was able to hold some space and some place that ensured that mental health measures were considered something that were essential to our economic, social and cultural development into the next 10, 20 and 30 years' time.
Brilliant. Thanks for that. That brings a neat summary to a lot of things you want to say. I just wonder, do you want to add anything, Marie, at this point? And then Ian, I might go to you and anyone else you have.
Thanks. I just wanted to say thanks to Kylie for coming to my talk yesterday. And actually, that's the talk that I gave at the Parliamentary Library, exactly those points. So I really wanted to reiterate that. And I wish I could have bottled what Colin said, because I really do love that idea of a mission. But Colin really took us to another level to ask ourselves about those mega trends that Kylie also raised. And I don't think that's out of scope, Pat, but I do think that we get ourselves dug down in the trenches, whereas we need to be thinking big picture. So that was the only thing. If we can try and think big picture, mission, wellbeing budgets, Colin mentioned, loneliness, that sort of space. That's all. Thank you. Thank you, Kylie, for coming.
Yes, I think classically we end up discussing two things. One is a kind of population mental health. And I think the opportunity of the wellbeing budgets discussion will broaden those with tied up kind of mental wealth kind of ideas. There's a huge opportunity in Australia at that level. I think it really does operate at the treasurer level, at the kind of higher level of Prime Minister and Cabinet Treasurer. I think there's a real opportunity there to work with that in its development with a longer term view of what is a wealthy country and investment in the social capital of the country. The other bit that is much more specific to the Mark Butler world is the healthcare system, the systems. And the slogan that we've tended to use in that area is right care first time where you live. That actually having a regional framework that you can actually look at, are people receiving appropriate care in appropriately timely ways in the major regions of Australia, which are about 52. We were lucky when Mark Butler was in opposition, because opposition people have some time on their hands, to show him a range of regional planning tools, dynamic tools, ways of doing that, which involves lived experience, involves people in communities to look in different parts of the country. And that has some significant legs, because what sorts of investments, rather than just having another thing in another place, another element, people often refer to another train carriage but no tracks in each area, which tends to be the way. So some of the problems with the legacy problem is people want a legacy of a thing, a brand, a thing I can say idea, as distinct from a functioning system in areas. And it is interesting with Mark that he was the minister when Julia Gillard did set up the National Mental Health Commission, and it was supposed to report every year for 10 years with a continuous improvement framework. Now, it never set up the metrics to actually do that. It certainly didn't go to the metrics being regionally based on an ongoing basis. And the politics of that is itself kind of interesting at another level. I was on a national health planning framework back in the Rudd government ages. People may remember this in terms of regional cancer planning, because outcomes from cancer were markedly different. Depending if you lived close to the Peter Mac in Melbourne or close to one of the major hospitals here in Sydney. And that led to the government actually going, you know what, that's unacceptable. We actually have to invest in the infrastructure regionally. So we had a regional cancer development. I remember Mr. Rudd running up and down Central Queensland and others, opening new centres, but actually making the investments in effective care where they needed to be to deliver reasonable outcomes, to overcome a really big issue, which was true in the cancer area 30 years ago, of massive inequities in death rates. Mark Butler was very good at the moment, I think, about talking about the equity issues. These are important issues also for the Albanese government. So I think there's a real opportunity to look at the regional issues, how that's organised, how that's measured and how that's planned, so that you could report in 10 years the continuous improvement in the number of Australians who receive the right care first time where they lived. And that then goes into what Angela was alluding to. You have to have a serious implementation process. And the implementation process has to be tied to a serious continuous measurement process. And just finally, the last thing Mark's keen about, because nothing I'm tied up with person myself in that area, is effective tools for doing that. And digitisation gives us much more effective tools. And I was on the National Commission, which Marie's been on, in 2012. We sat there going, you know what? You could measure it in 2012 by actually using simple technologies, people's experiences every day, plus other areas. Unfortunately, at the time, the health department didn't want to borrow it. They wanted to go back to central agencies and the existing systems, which we know are grossly inadequate, which are now enable people to get involved in their care, but also to know in real time what is the variation that is going on, what is the unacceptable variation. So at the end of the day, you could end up with a mental health system that functions as well as our cancer system. You know, our cancer system around Australia now, no matter where you live, is amazing. And that was not the case 30 years ago. It was not the case. And the investments of the Labor government, then the Rudd government in 2008, was a massive change in that. You know, I take up your point, these things are possible. One of the problems we have in mental health, the constant sense that it's not tractable. And Mark Butler himself gets a little bit, it's complex. Yes, it is complex, but it does involve housing and employment and social sector. And also involves place in a particular way, but it is tractable. And I think that's the kind of leadership element that was being alluded to earlier on by Kylie, which is really important. The federal government has the capacity to lead. There are actually very cooperative state governments around the country now who want to do things differently, but they need to operate at a different level. They need to operate cooperatively in the 52 regions in which we live.
Bill, we'll go to you, and then I just want to try and pull some of this together.
Yeah, I just wanted to reiterate a little bit about what Ian said, because my experience, I went through the process of when the Medicare locals transition from, and there was a whole shift of how commissioning services along the regional areas were implemented. And I think from my experience, what particularly when we're at a Medicare local level, which alludes to the 52 areas that Ian's addressing at this discussion, is that there was a real ability to actually focus on what the regional needs are. And what I found as a commissioning part of the Western Sydney commissioning team was that there's a lot of noise and a lot of advocacy from different places, but there was never really ability to actually capture the measurement and the flow of quantity of services that needed to be for that specific region. I think that's one of the biggest things that's missing at the moment, is it's a little bit of hearsay and lots of noise around who should be advocating for what part of the system and what sort of illness or what sort of clinician or clinical body. But there's never been an ability to actually look at it objectively based on what the data and the regional needs are. And so if I can turn that into a little bit of a perspective from a personal point of view, what we often found is those people on the ground, those people that really needed help, often were confused by the number of layers of services coming in and out and changing through different branding, different sort of services, different criterias. And so there's often been a flux at what happens at a community level, that there's no consistency. And what I found that we started working on, and obviously things changed through the PHN cycles, was that if we had an ability to actually coordinate some of these local government PHNs, local health districts, other services at a regional level, you can actually start commissioning things much more sequentially and coordinated, that I think actually got down to the services for the people that really needed it, because the confusion is probably half of the battle of actually getting services or getting help. So I'll leave it there. Yep.
I just want to jump in and support 100% what Bill just said. It's very heartening to hear you say that, Bill. I think going back to economics here and the treasurer, what we've got a problem here with is applying this market-based competitive tendering type approach, which the PHNs believe, in their DNA. They've got to do that. It's resulted in a terrible fragmentation of the system around the country, and lots of very bad side effects, like Bill is actually describing very well. Doesn't mean that you can't have regional commissioning, but it's got to be done in an integrating way, bringing people together and integrating services, not fragmenting them like we're seeing at the moment.
Quickly, yep. Just mic on, yep.
Just quickly, the Productivity Commission's recommendations were clear about the need to set up reciprocal state regional planning entities for the Commonwealth to liaise with the local health districts or their equivalent in each state. Currently, the primary health networks all have different models. There is no consistency. They do not play a standard role in regional mental health service planning, let alone data-driven, or in order to realise more person-centred, psychosocial, empowering models of care. We've got a review of the NDIS and everyone who's left out. We've got the creation of 2 national peaks for carers and consumers in mental health. We've got the bilaterals that need to be rewritten and purposefully set up this reciprocal planning process between the state and the Commonwealth, and then that planning needs to be funded. We went through an exercise with CESPN, where the peaks and others and the LHDs collaborated as far as they could on planning services. It was not core to the way things were set up. So if we're going to measure something, we need to be measuring the way you need to spend to save. You need to invest in less acute care so that you don't have people requiring more acute care, but when they do need it, they need to get it right away and not in 6 or 12 months' time. So if we should be measuring the minimisation of suffering and disability that we are able to achieve by implementing these proper processes, and comprehensive skills-based mental health education in schools would be fantastic.
Yeah. Thanks for all that. Lots of voices, lots of perspectives, and as I said, that's the Mark Butler challenge in a way. And I suppose I just want to focus on 3 questions that emerge. I suspect if you had a private ballot in the room, lots of good ideas, right? Lots of good ideas, all with merit. You could mount strong arguments to be advocates, I suspect, for all that we've heard. But almost the diversity of we should try this, try that, just kind of is so indicative of a system under great stress and great strain. In reference to it, but one of the reasons I'm keen to kind of engage and work on this, and have been over the years, is that at one time in my family, we had a surprising kind of severe kind of cancer diagnosis, and we're also dealing with severe mental health issues. And the difference was astonishing to me. The level of precision science, integrated teams and engagement on one, and the other feeling lost and overwhelmed in a system, everything from, we talked about emergency departments, all the way through, just kind of astonishing to me. And that's one of the reasons, I was keen to connect with Pat years ago around trying funding for mental health research. So much work to be done. I think if you lift it up to at the higher level, it strikes me, and I'm the outsider here, the opportunity is to try and create a vision about what can be achieved in 10 years, a broad direction of travel that everyone agrees on. And then if you get that, what I've seen in the past, if you get that trajectory and momentum right, then there are lots of things that can come in along the way that kind of, can be well articulated, generate support, find funding pools, but that's still moving. That's moving in that direction. There's just a sense of we're moving in that direction. That's what we're trying to achieve. I think the first thing that kind of emerged, though, I find kind of fascinating. And the one point, we have no blueprint, so they are not executing to a plan that is evident here, even though we have a plandemic, 53 reports, 9,000 recommendations, and the fundamental disconnect between so many voices, so many views, so many recommendations, but still not a clarity of plan on what it is we're trying to do, or even where we're trying to get to, I find amazing. Yeah, just Michael.
Mark Butler held a meeting, I think at the end of January, in the wake of the better access sort of issue, in 80 people from the sector in the room. And he went around just like we've done today.
Yeah.
And because there were so many different perspectives and different views, just like you said, he was able to walk out of the room saying, well, we don't really know what to do now.
Yeah.
But that was the plan, and that's to buy a bit more time, right? But I think like Colin said, he will do something, but we've got to get over this, because all the things we've been said, I think, are compatible with each other.
Yeah, so do I. Yeah.
So it's got to be unified into something that high enough level that people don't undermine it, and don't allow them to.
I agree. So I think there are a whole series of kind of tactics in a way, or implementation kind of devices that help advance to the point. But is there clarity around what it is, what success will look like in 10 years' time, and where we're tending towards at a higher level? I think one of the things that confuses me a little bit about this, I was saying to someone the other day, if I was still editing newspapers, one of the things I'd do is I'd take 2 pages and just run headshots of people who've been appointed to conduct major reviews for this government. This government really has already in a year commissioned lots of reviews, and even in education. You've got the big Accord consultation on the future of higher education. There's a new one on the future of schools funding. I'm doing a little one on the future of teacher education. There are 8 or 10 in the education portfolio alone, and there are many, many, many others that are rolling out. Australia's relationship with the region, all of these questions. So I find it kind of interesting that with a lack of a blueprint and the minister's reinforcement around that he doesn't really have a plan. He wants more time to get a plan, but he hasn't announced a mechanism whereby he'll get a plan, because he hasn't announced the Royal Commission into Mental Health, the eminent panel to provide advice by, So I'm kind of curious as to, how he will get there, It goes to, I suppose what you were saying, Collier, and you were saying yesterday, Murray, the question is, with all of those reports, do you now need the blueprint, or is there basically enough out there that the minister can pull it together and do it? Is that a start? One of my questions is the need for a blueprint a key starting point or not? Or is that just going to be the 54th report with another 100 recommendations? Yeah.
Well, it's a commitment to a blueprint. I mean, I think the Productivity Commission did a pretty sterling job at sort of pulling things together.
Yeah.
Delivered a 1,000-page report. It's sort of 1,600 pages. Thank you. Well, I think that there was it neglected the private sector and the role of the private sector and how that's going to integrate with things, and that's a whole body of work that actually has to be part of the conversation, because it's a huge part of mental health service delivery in this country, and no one's willing to sort of go anywhere near it at the moment, because it's part of the big Medicare family, and that's an impossible animal to be able to tame. So I think there is a lot already there that they could start to that forms the basis of a blueprint. They just got to get whoever it is they're going to get together. It's going to be their eminent panel or their consultative committee or their summit or whoever it's going to be, to come together and to map something out for them that they can commit to.
Can I say it's a bit more complicated, because you remember Prime Minister Gillard and Mark, that was Minister Assistant Prime Minister, set up the National Mental Health Commission for exactly that reason in 2012, and it still exists. And it's supposed to have written a Vision 2030 document and other sets of things during its current life, etc. So I think not only does it have a lot of reviews, it actually has an agency and mechanism that's
meant to be doing this.
Yeah, so people like myself and Alan Fells and others think that Alan always thought it should be independent statutory authority, reporting, and then being and having an investigative capacity too, I might say, and having a genuine capacity to comment on the system for government in a continuous way that would do that, rather than having to have one-off advisory bodies, expert panels, etc. Now, having created that whole thing, and obviously it's been in the news over the weekend in an unfortunate way. So there is a kind of a machinery of government problem that sits underneath that as well, that they did try to do that previously, to not have another inquiry every 2 years or 3 years, 4 years. Of course, immediately after the government's elected, that's exactly what happens. But
one of the interesting things I think you can see, though, in other portfolios at the moment, is that ministers are trying to set up blueprints that provide them for a pathway to action. That's what I think you can see in education at the moment with their big accord review. New minister wants a blueprint on how to engage with the sector, and it's setting it up for him. And so I just think that's an interesting kind of open question, and whether in fact that then gives a legitimacy and a mandate, that will spell out what success should look like and drive its way through. Now, just any more on blueprint, and then I want to go on to some other kind of key issues that,
So this is about the blueprint.
Yeah.
I having looked at most of those 55 inquiries, I can tell you that it's pretty soulless, and I wouldn't go back there and ask for 54 unnecessarily. However, what you're really missing is an agreed set of priorities. So what I think we need to be conscious of is that governance in mental health has actually become more diffuse, not less. So we did have a plan, and now the plan has actually been broken into sort of something that sort of exists nationally, but actually exists in an opaque way through 8 bilateral agreements, as Jonathan was talking about. So the key, in fact, you could even go around just about all of the points that we've made, and from those actually articulate what is the underlying principle. The underlying principle, which is not articulated in any plan, is that we will intervene early, Pat. Is that we will involve co-production. Is that we will have proper planning. Is that now that agreement is missing. And so what we're allowing and what we're permitting is, in fact, 1,000 flowers to wilt instead. So that each agency and each area and each department and each state government and each successive federal government is investing in sporadic fireworks, some of which they may feel proud about, but fail to connect, fail to adhere or cohere. And so it's that sort of capacity to explain why you are doing things that is really missing.
said about cancer. That's the goal. That's the ideal, isn't it? That's the holy grail, isn't it? To get to that level. Isn't 30% of the health budget spent on cancer? It's 18% of the burden of disease. So money is very important. The amount of money spent on mental health is only 11 billion for 5 million Australians every year, spending 40 billion on 500,000 Australians with physical disability. So in the NDIS, so the mismatch in funding is a massive, massive problem.
So I just want to yeah. Okay. Let's quickly hear from those on the screen. Then I want to go to the staffing question that underpins a whole lot of the issues that we raised here. So Colin, we'll go to you, and then Daniel and Bill.
Yeah, thanks, Mark. I'm a bit like you, Mark, where I consider that I'm the outsider here, and we've got a lot of very skilled mental health industry experts around the room, around the Zoom. But I just want to highlight that I think it's very easy to be trapped in the past. And I think that the past has changed the future very, very dramatically on this topic. What I mean by that is the next 10 years is going to look very different to the last 10 years. We've got corporate Australia desperately wanting solutions for the first time in this space. Every CEO in the country is concerned with mental health. They're concerned with the costs, the interruption, the absenteeism, the issues on their workforce. It's such a big issue. I think the insurers who are not represented here today, it's costing them somewhere north of $6 or $7 billion in annual claims, mental health related payments. That has become, for the first time in the last couple of years, a massive, massive cost to their bottom line, and a problem that they have no solution directly for. So I just suggest, Treasurer Chalmers is all over this stuff. It's absolutely in his wheelhouse, to the point that Chris Rain, here today, head of mental health for Australia, he and the Treasurer and I had breakfast a couple of Tuesdays ago and ended up on the front page with a photo on the Australian Financial Review the next day. That would never have happened 5 or 10 years ago. That mental health was actually on the front page of the AFR with the Treasurer, with him being clearly interested in how does he fund it, how does he solve for it. So I think we need to definitely escalate this to a 30,000 foot view. How do we now get front footed? How do we create and design, innovate a new future? What does that look like at a macro level, given that we've only got 40 minutes left? And what are the next steps?
Okay, Daniel and Bill, and then Dee, I might just want to bring you in on how you see the politics and the political engagement around these issues, if we can. So Daniel, we'll go to you.
So just to, I think, chime on the points about cancer, which is perhaps the other area I have some knowledge of. The difference is, so if you look at the National Mental Health and Suicide Prevention Agreement, there's 15 priority populations. That, when you break it down, turns into 3,456 sets of people because of the numbers of groups in each population. That's an impossible kind of thing to try and manage. For cancer, they talk about measurably better outcomes, and the big measure is the 5-year survival rate. It has no particular kind of empirical value, but it's a useful number and people understand it. And in cancer, the advances were because the sector could say who receives what care from whom, with what cost, at what benefit. They could say, where is the variation? Where's the unwarranted variation? And then they could say actually what works. And how do you know what works? Is you have a what works network, because it actually can adjudicate independently on the evidence. And so to Seb's point, accountability for what? Well, accountability for what works and to do the things that work. And we are fabulous at admiring the problem in mental health. I mean, that's what we do. But the solution, some of it is directly in, I think some options are directly in front of us. The way Headspace address that, the way the cancer approaches address it, because most of the other approaches are generally inflationary, and we risk amplifying the variance rather than constraining it. And the absence of a national what works network, a NICE or a NICE light equivalent, I think is a major impediment to progress, because everybody can bring their own instrumentality to the solution, and we quickly descend back into this chaos of everything works in some context somewhere, and we go around admiring outlier places like Trieste that only work in Trieste. Lovely to visit, but they don't really tell you something useful. rather than looking at the solutions we've got that actually are working and delivering at scale.
Yeah.
And we're blind to those. And I think we are literally blind to those because we don't measure.
Thanks, Bill.
Yeah, I was just going to make a comment a little bit about the money issue, because I think obviously the government is going through a very long, prolonged economic recovery process. And so our approach to Mark Butler needs to have that factor in there to say, you know, whatever we propose has to be within the context of the economic recovery process. What I will say, two things. One is, contrary to what Pat just said, I think that there is a reasonable amount of money in the system. It's just the way it is used is not very effective or efficient at times. There is a lot of waste. There's inability for us to be accountable and understanding what the outcomes are. And what I find that there's quite a lot of issues around inequity and access. So people with a long-term mental illness who want to maintain their illness and be preventative care sometimes don't get that help. And some people who have an episode of care sometimes gets overly abundant care, depending on the region or their access to different services or whatever they might be. So there is a smart way that we can approach the minister with this. And I think one of the key issues is technology, not only obviously for the end user technology, but also the planning tools and getting quite good data available based on the needs of regional needs. I know I'm stressing this point, but I think the equity issue is a real issue. There is a reasonable amount of funding in the system, but it's not well used. And I think that's something that we need to be focusing on as well.
I want to come back and talk about those systems issues in a minute. But Dee, you know, what we're trying to just kind of work our way through here is how you take a myriad of good ideas, all important in their own right, but to frame an argument to government, perhaps an argument to government over the next 6-9 months or so. The target's a 2024 budget, but then looks beyond that because you'll immediately be an election cycle again. To get some long-term ambition rather than simply short-term tactical plays, and kind of sets us up for a long ongoing policy engagement around investment in in significant mental health reform. And you've heard all the ideas today. Just give us some insights on how you think government will think through these issues. And as we come to kind of frame this, perhaps persuasive and engaging ways of being able to do that.
Yeah, I think going to them with a whole myriad of ideas is just going to scare the fuck out of them anyway. There's no doubt that the NDIS has made people incredibly nervous.
Yeah.
Like everyone knows how it's been stuffed up. So I think what Bill said was really important. This idea of waste, I think whatever we present has to have an absolute degree of transparency about it, that the government knows they can put this in place, and we're presenting them with a solution, and that's what Mark said at the beginning is so important, that already has transparency built into it so that they're not going to get caught down the track with wastage. And I think Daniel's point about evidence is so important as well, and so tricky because it's not like a cancer cell thing, like it is different, and we all accept that. So what I feel like is you go to them, and also, do you know what? We also have to accept that whatever solution we go to the government with, some people around this table are not going to be happy. That's just how it's going to be. And at some point, we just have to say, this is where we need to start. Because if we keep waiting for everyone to agree, we'll never get anywhere. And we'll be having these conversations in 10 years' time. And everyone will say, well, this is important, this is important. Yes, they are. But what can we do now? Which is why that schools thing seems such a really smart way to start, because it's kind of, there's the systems there. We've got those ridiculous chaplains there that can be swapped out. I think you present them with a 10-year plan, but gives them a 1-year sugar hit that they can say to people, we're going to do this. It's not going to cost this much. It's going to employ more people. It's going to help our kids. And then you give them sort of a 2-year and then a 5-year and a 10-year that they don't need to talk to the public about yet until they've got the NDIS fixed. That would be my sort of overview on that. Give them a nice little sugar hit to start, and then they start to trust us.
Interesting. Yeah.
Thanks, Dee. Yeah, I guess, Mark, was just a sort of quick time and process check. I mean, incredible plethora of ideas and lots of big ideas in there, but I'm just also conscious of half an hour left.
Yeah.
And not that it's all about us, but we are a modest non-profit in our own right at Australians for Mental Health. And I know, Chris and the team were very keen to try and push us forwards if we could to stress test a little bit. And I guess it's what Dee calls that sugar hit. We're conscious. It's great to have these 10-year sort of perspectives and visions, but we're also conscious of what is it that we can get up and the runs that we might get on the board for this next budget cycle. So I was wondering, Mark, if we might sort of move into that part of the discussion.
So I wanted to talk about the employment staffing capability question, because I think one of the ways that I was mulling about it was, if all or any of these proposals got up, what's in what is a condition precedent that you're going to need in order to kind of do work of this ambition, and how fundamental, broadly, irrespective of precisely who they are and where they operate, is a staffing shortage in the sector absolutely critical to any part of our ambition moving forward. And so one of the things I think a preliminary meeting was kicking around was a policy proposal that said there needs to be, right now, no regrets move for the next 10 years, a significant further investment in the development of the mental health workforce. And irrespective of what blueprint, what commission of inquiry, what particularly policy levers you're looking at, if you don't have the workforce, you're not going to be able to do it. And in a way, I mean, the other things I thought was very interesting was all that discussion about systems, Commonwealth, state, local alignment, the need to have credible data sources, the need to be able to use those data sources to drive accountability, and all of that. I think that's all very compelling. That's not quite as compelling kind of publicly, but that's the work that needs to be done. And whether in fact that is a pigeon, that's a pigeon pair in putting to government. So I'd like to kind of draw people out on the workforce proposition. And I think in some of the material was circulated, the sense of, to meet demand, we need government and sector reform and an investment. And there was discussion about doubling the mental health workforce over 10 years. I think there will be, if you pick up Dee's point, considering NDIS, will there be sticker shock and nervousness about that as a 10-year commitment right now? But is workforce where it all starts is a question, I think, for us here. Yep.
So I really like that question. I was involved with Reach Out several years ago in putting together a report called Crossroads, which basically showed that you could conduct any kind of breeding program and not be able to come up with the number of mental health professionals you would need to meet demand. So I'm afraid I'd go back to Pat's point, which is really that you can't really divorce the question of workforce from the discussion about model of care. How do we want these people to work? And so if we were just to put more people into our system as it's currently designed, I don't think we would have the bang for buck that we would be desiring. I think it would be an inadequate solution. You'd have more people working in models of care that are based on, say, fee for service or based on partial delivery of care and so on. And so I think any discussion of workforce has got to be associated with the design and role clarity discussion as well.
We were talking about that before we came in, and if you look at what Mark Butler, and we've had discussions with him in the wake of that round table, what he's struggling with is a much more bigger, well, obviously a much bigger problem with the viability of Medicare and the fee-for-service system. And we've got to, coming back to Dee's point, we've got to factor in what we say around this with what they're going to have to do more generally in the health system somehow. We certainly don't want more psychologists in high streets in Malvern and Double Bay. That's what will be the outcome of a doubling of the workforce in unreconstructed. So some sort of new thinking about the financial model and whether we go back more towards salaried, integrated. So the model of care, multidisciplinary teams, which Stephen Duckett's obviously been lobbying pretty hard for, and we agree with that. So salary-based multidisciplinary teams, incentives for that sort of model, then you can have confidence if you train more people that they're going to be in the right model of care and also in the right places, and incentives to get them into regional and outer metro Australia as well, with lived experience factored into the workforce as well. So I think it is not just a simple number. Certainly the number is very acceptable, doubling it, that would be great. But how are they going to work?
So I think on frame, the question I think is clearly not just doubling the workforce as a panacea for nothing really. There's a whole lot of other reform that needs to take place. But given lead times and given what we face today, is pushing more, getting more throughput of professionals, recognizing at the same time you need to be doing all the other issues people are talking about. Is that a starting point? I think that's the question. Daniel, we'll go to you and then Bill.
So the workforce question is interesting in terms of scalability. I spoke a little bit at a conference earlier this year on farming scalability. If you look at farmers 50 years ago, the efficiency of a farm using technology is 6-fold increase over that period of time. If you go 30 years ago, you spend an hour with a psychologist. You come today, you spend an hour with a psychologist. It's the same hour. The price of the hour has gone up, but the time of the clinician is exactly the same. And that's effectively a completely unscalable model, because you can just make it bigger and bigger and bigger. And and that's the basis of the MBS system. And to Pat's point, we've got a system designed not for scalability. We've got a system designed for our fee by hour, and that's what you'll get. So farming's somehow got at least 6 to 8 times more efficient in 30 or 40 years for an hour of the psychologist than an hour of the psychologist, and you get an hour's worth of benefit as you would have 30 or 40 years ago. And I think in the absence of using digital technologies, all we can do is just have an accumulation of workforce in the hope that something magic's going to happen when we reach kind of a saturation point where the workforce matches the community need, which it never will.
Yeah, I appreciate there's some good comments coming in the chat. So we'll get some of those read out in a minute. Corinne, we'll go to you and then Bill.
Thank you. I just wanted to comment on the statement that had been provided to us, that there was really no identification and inclusion of community managed organisations workforce other than peer workforce. And I think this is an area that is dropping out of a lot of the conversations about workforce. Because we really want people to be to receive the care they need in the community, there needs to be a mental health workforce that obviously includes, importantly, peer workers. But it needs to be broader than that. And that certainly isn't indicated in the statement that we were provided with. And the sustainability of the workforce in the light of what's happened with staff moving into the NDIS, I think that's an issue that really needs to be looked at. Thank you.
Thank you. Bill?
Yeah, just to the point of the workforce, I think that's probably one of the key ones I think that we need to inform the government with, because it's not just a matter of more, because obviously we need more, but it's how they're used. One of the things I was very fond of that we tried a few years ago is to get some of the hospital-based staff to work in the communities, at least in partly transitional part-time, which then can actually assist in informing the people in primary care as to how to manage mental health. So we did a pilot, which we were very fond of, which is getting a psychiatric liaison officer from the hospital who's based there, and then 1 day a week they would spend in those hotspots associated with primary health. We could do similar sort of things with Headspace and other community mental health services as well. But that would elevate, I think, the capability of the workforce. Not only we need more, but how we use the different levels of professionals is really critical, because that's where you get the amplified effect of the services. So it's getting people to liaise not only at a hospital-based care, get the lived experience into the community, but also transition them based on rural needs as well as the different levels of care that's provided. Because the last thing, and I'm a psychologist, the last thing you want is have a plethora of more psychologists, but they all have their diaries and they book an hour sessions. What we need to do is have that interaction with services that are on the front line to to give that periphery of care, not just the 1 hour sessions. We really, if I could give you one message that I think is really important, is to get the psychologist or psychiatrist and other healthcare, even lived experience, to look beyond that point of care, and that how we actually support that with the government is going to be important. Thanks.
Yeah, so I just wanted to make a comment. Definitely agree about the kind of workforce issues now, and we see that in the kind of insurance and corporate space in terms of access to treatment. But I think also, you know, to add, thinking about the future, what should that workforce look like? And when we think about prevention, I think we see a huge role that, you know, schools play, but also community services, and how do we build those people up to be able to provide kind of different prevention services. And I think that's going to make a big difference because we're not just relying on the health workforce then. So yeah, just wanted to add that point as well.
Yeah, thank you. I agree with all the points that have been made around workforce, but we have a workforce crisis right now. So in the clinical workforce, in the public sector services, we're having great difficulty attracting people. Nurses have left in droves from as a consequence of COVID and the difficulties. Subsequently, we've got psychiatrists. One of the unintended consequences of telehealth is that psychiatrists are leaving the public sector because they can provide telehealth services from home and have a much better lifestyle. And so that we're having great difficulty at attracting people, particularly to those difficult to staff areas in the outer metro, the really busy outer metro places. They're not really outer anymore. They're sort of getting more and more central, but they're extraordinarily busy and traditionally very hard to staff. So we've got that, we've got nursing, and we were also, even in the private sector where I'm working in the private hospital sector, attracting nurses to novel, fantastic services is almost impossible. Getting psychological staff, clinical psychological staff, very, very difficult. So it is all part of that idea around what sort of system do we want to operate and who does the triage in this system. And then we've got to sort of really think about that whole point about how do we triage who gets what? And that's the big problem with our existing service. GP is the triage agent at the moment, and who they don't really triage. They just give somebody a referral to see somebody that they can try to find to get a booking with, and then that's it. And so we've got to have a real rethink about how we prioritise service delivery within our private sector system.
Yeah. Now, is someone in a position to read some of the comments out that are on Zoom, because we can't read them on Zoom in the room? So yeah.
Yeah, there's a couple here. I won't name them all, but on the workforce issue, talking about removing HECS for mental health degrees, incentives to work in rural, in mental health care. Kayleen made a point around how do we confidently train people when we don't know where or how they'll work, which kind of goes to the accountability measures issue before. Dee said we need socialism in mental health.
I would say that, but it does go to that point about we don't want to get in the situation with aged care and childcare where the government's constantly, and Medicare, where the government's constantly topping up fees and they just get higher and higher and higher. So it goes back to that salary thing, like free HECS, but gee, you have to work in a government-owned mental health facility. Like, you know, I feel like socialism is no longer a bad word after COVID. I mean, I wouldn't be out there screaming about it, but it's not a bad way to look at it.
Could I just add one thing about so I think your question or challenge was really good to start off with about the workforce. I just wanted to come back to that just to say that while we've come up with a whole bunch of reasons and issues and so on, as usual, whenever we come together as mental health, what's really important here is these models of care do exist. It would be eminently possible for us to actually say, this is what the evidence suggests should be done for people's different circumstances. This is the shape and nature of care that should be available regionally, and how it should blend clinical and psychosocial needs in order to meet a person's requirement. Now, the fact is, again, that we simply have not done that. We simply have not actually stated what's the way we should be responding. We haven't articulated that. And so it makes it very difficult then to say, well, what's the right sort of workforce numbers? What's the way we...
So it just makes me wonder, on this, I suppose I was mulling about it, you've reinforced it, whether a workforce strategy is actually a Trojan horse for the other issues, really. That if we say we don't want a Royal Commission, we don't want another eminent panel, there's lots of advice out there. But what we all know is there's chronic staff shortages today. Cannot, even the services of trying to deliver today, we are chronically affected, and it's got dramatically worse through COVID. So it's a very kind of pressing issue now. Our ability, one of the interesting things that universities are seeing, you can see it in teaching, even the availability of places at a university does not necessarily mean that they are being filled. So there's increased demand. You could create a whole lot more places, but will you attract people in? But if in fact you said to the government, we need a 10-year workforce strategy rather than a 10-year mental health strategy, whether that is the mechanism whereby you build into that, because it's not just a raw number, a doubling of.
No, but they've just produced one and it's absolute rubbish.
Right. So that's what So, and who has produced that?
Well, the Department of Health.
Yeah.
But can I just raise one other point, Mark? It's relevant to what I think Bill and maybe Colin and Angela were talking about, and to basically pat the Productivity Commission on the back for one thing that they did, which was actually to show the incredible inefficiency of public sector care. So you've got clinicians who are paid to see patients, that's their job. They're trained, case managers, allied health, nurses, doctors in the public mental health system around the country, the state-funded system. They're spending 2 hours a day doing that, spending 8 hours, the other 6 or 8 hours, however long they're working, filling in forms, doing risk management, butt covering, all the usual sort of, stuff that the red tape that's been introduced into the system to stop them doing what they were trained to do. So the scaling issue and the efficiency and the capacity issue could be addressed if that one was addressed. And I don't think you'd get resistance from the clinicians for that. You'd get resistance from the minders and the kind of the management structures within the system and the safety, the quality and safety committees. They'd freak out. But the best way to improve quality and safety is to provide better care. So that's another avenue.
Yeah.
I get very frustrated.
Mike, yeah.
I get very frustrated quite a lot, particularly with the Commonwealth planning processes, because so often they just come up with a brain fart and vomit it on the states and expect them to lick it up and do something with it. And this is the best way.
We get it. Yeah,
this is the best way of wasting money instead of making it effective by just making you use your increase for inflation on something completely new that is not connected in any way to anything that you've got or filling any gap that you don't have. So, I mean, I think that instead of maybe coming up with a detailed proposition for each of these items, we should come up with a process, a recommendation around creating the plan and creating the accountability, creating the data set, so that there is something that can then go on and co-design the different components, rather than making the case for a particular platform at a particular election. It's much easier to make the case for democracy, to build the constitution and to get the framework in place. And maybe that is the best and most effective thing we could do. And it's something that they could do, and they don't have to commit to solving all of these issues a priori before we start.
Yeah. We're just going to hear from a few more voices, and pretty soon Chris is going to summarise it. So it's ready to go. Which is why he's on the big bucks. Colin, over to you.
Yeah, just my last comment for the day, and thanks again for everyone's contribution and comments. And I through you, Chairman Mark, you've done a great job. I don't know how you and Chris are going to pull this together in some cohesive way, but good luck on that. Look, I think there's a lot in this to unpack and make sense of. I just want to say one quick controversial comment. I think it's controversial, and what to me seems to be a bit of an elephant in the room. And this is not to upset or undermine my good friend Pat and other psychiatrists and other professionals in the room for all the great work you do. But I feel, someone with lived experience, that my dozens, probably honestly hundreds of psychiatric meetings and psychologist meetings over the years has not delivered me very much. I've found it fairly ineffective. And I'm not saying that's for everybody. I know everybody has a completely different experience and different issues and so on. The thing that actually, so my call out here is what we need to do to innovate to actually solve some of these issues. I found MDMA the most useful thing to have me have a life that works. It is now legal through psychiatrists, through the TGA, as is psilocybin. I was part of that campaign through My Medicines Australia and others. Mark Butler was intimately involved in that. I met with Mark on this issue, and it's been waved through in fairly short time. I know that seems controversial to some, but hey, guess what? It works for some, and it's innovating. It's trying new things to lean into PTSD where it's very effective, and depression where it's mostly effective, and so on and so forth. I'm one to say candidly, hopefully courageously, that it's worked for me. So it's now legal to be able to use that as a treatment potentially. And I just think that as a sector, we also now need to be a little more open-minded and a little more innovative how we provide support and service to people with mental health concerns, which is clearly very complex and hundreds of different conditions and diseases. With that, I'll stop. Thank you for having me here today.
Okay, thanks for being part of it, Simon.
Yeah, so just following on from the point I think that just Colin made, I don't think part of the blueprint clearly has to, and I know we've spoken about address the social determinants of care, and I keep reflecting back on the number of people I see in emergency departments who sort of say no matter how many medications, no matter how many psychologist appointments I see, if I'm still living in my car, I'm not going to get better. So clearly part of that blueprint needs to address things like, as we said before, jobs, homelessness, and those issues. Also interesting. The other just quick point is on jobs and employment. Again, we need to carefully think about how we reframe. I think that the careers and the attractiveness of trying to get people back into the mental health sector, because similarly to nursing staff and emergency departments, it's all been, this is terrible, this is shit, why would you want to work there, it's stressful, it's burnout. So I think part of that, obviously that blueprint or that strategy, is how do we re-engage the attractiveness, I guess, of careers in mental health. And that's a really tough thing to do because there's been so much negativity. Not quite sure what the answer is and how we do that. We've seen some stuff about HECS fees and financial incentives, but clearly it's going to be a long build to really get that workforce engagement.
Okay, well, look, thanks to everyone. I just want a few points of summary for me, and then Chris, John, others may from the Australians for Mental Health might want to bring some thoughts together and outline where we go from here. As I said at the beginning, I think we can be optimistic about where we are with the federal government and with the state governments, really. I think there feels an alignment around purpose that hasn't always been the case over the last decade. And really, you would think that particularly with how many state and territory governments are aligned with the federal government politically, again, it kind of feels like a window of opportunity here. And but I do think the reality is if you just burst in the door with trying to be the loudest voice around we need the money most, that's the hardest way to go about it. In a way, you've got to frame the challenges the government face and position yourself as being in the solutions business. You're coming with answers to help them be successful. And also you're coming and recognising the reality of what it is they're dealing with. Fiscally, as challenging a position as the government has been in decades here. And so the pressure around fiscal responsibility and budget repair, I think the politics of other grand visions that are blowing up on them, and NDIS is the one at the moment they know they've really got to wrestle down. But at the same point, some optimistic signs around mission-based government, well-being government. So you've got to be in there kind of speaking the language, I think, and bringing the solutions. One line I've had to hold on to over the years that I like is that innovation loves constraints. The brightest ideas really come, if you really want a great innovative solution, it wouldn't be the dropping of $100 billion on the table here, nice as that would be. We're not going to be in that position. We're always going to be in a position where there is real fiscal constraint here, but that's where real innovation comes from. And I think one of the things I'd take from the conversation today is that a sense that whatever we go to government with needs a recognition that the system needs to change, Commonwealth, state, local, Data provides an incredible opportunity. Technology and provision of service provides a great opportunity. And it doesn't just provide a great opportunity, it provides a great mechanism for government around accountability as well. For the first time, to really get insights on what is working well, what represents successful investment. So they don't feel like they're just pouring the money into a black hole. But at the same time, we're going to create a system that provides real feedback and real evidence for them. And then I think the question, almost where we started as well, where do you best start? I think there is real merit in what Dee said as around a confidence builder, no loss, politically attractive thing to do that will get attention, that might get attention of a Prime Minister, a Treasurer or an ERC, that shows they're at least on the journey around mental health. But I think the other challenge for us is, what are the issues that if we don't start now, in 10 years' time, our ambitions will be strongly constrained. And that's where I think the lead time around the workforce development question is very significant. Now, I recall, Pat, you'd said to me before that the workforce plan developed kind of was very lackluster. But the reality is you need a workforce plan that's not lackluster, that allows you then to be able to explain to government where the need is going to be. And I do actually think that kind of mechanism, the workforce conversation should be a conversation that then goes to modes and models of delivery, difference between public and private sector delivery, difference between city and region. There's a lot that comes out the back of a sophisticated workforce plan. They've done one broadly for health. They're doing one for school teachers, because the skill shortage has made workforce planning pressing for them in a way that they have not needed to. And so whether in fact it's reframed, renamed or rebadged, the opportunity to again get into that workforce planning conversation, I think, is important. So I'm going to pause there. Chris, I don't know whether you want to take it from here.
I think I like the idea of that being a Trojan horse for reform and actually getting something through that way. I think as a policy platform, that seems right and something that we need to work on. The thing I feel that is missing, that is really powerful, I think, alluding to Pat's point around having a mission, and even to your story about what you experienced in your family on the difference between cancer care and mental health care, is the narrative of our system. Like, we don't have a very, and I think to your point, with the 80 people talking around the table and then, okay, we'll just keep going. There's no real vision or imagination of what a really great mental health system ought to look like. And for that ought to be a vote winner. I think that's something that is really missing. And picking up Dee's point around having specific outcomes, when I think about interviews that Paul Keating does, he talks about, when I came into Parliament, 2 in 10 people finished high school, and now 8 in 10 people finished high school. Those specific numbers matter and that build on that narrative. And we just don't have that politically in the mental health system. And I think that's a role that Australians for Mental Health ought to play. But I do think coming into this budget that the workforce strategy and forming some coalition around how that looks like as a proposal comes underneath that. But around that is the story around where our mental health system is going. And that's just not quite there, I think, as something that pulls us forward.
If you jump into the workforce issue, as is demonstrated in the Sydney Morning Herald and others in recent days, the workforce issue itself is highly political, and there are many contested views. So the simple idea that one should expand the number of unskilled workers, if you like, and then of lowest level of skill, and simply everyone gets a service type idea, is strongly promoted in the sort of public domain, that there's an existing workforce who just isn't getting Medicare type ideas. So it's highly contestable. Some of us obviously here, and myself and Caroline Hunt and others saying that is not actually the answer. But it is politically contested because people want care. I mean, like, people have facing real difficulties. Many more people are locked out of mental health care. So this comes to the issue of triage. If you're going to go in the workforce area, just be aware you're going into one of the actually most politically contentious. I agree, it's actually one of the ones that's most fundamental to reorganise the system. It's also one of the ones most politically contentious. I think Mark Butler's done a really good job actually up to this point, not continuing the 20 session issue, making it clear that equity matters, making sure who gets that care. He's been quite good about saying that the public pressure or the popular pressure is simply just any care will be better. And if there's anyone who's got any degree of skill, they should be able to actually access what everyone thinks is the holy grail, fee-for-service Medicare services. So that has its own political sort of momentum, as is happening around GP funding, etc. So the minister has tough things on his desk. So in one sense, thank God there is fiscal constraint. You know, like, at least you can say there's no money. You know, we can't do it. But actually, the real reasons not to do it are not simply money. They're about what is the design long term that would actually work.
Look, I guess I'll just sort of finish by thanking everyone again for all their support and time. I think what we're really keen to do now is try and synthesize this and a lot of other thinking and conversations we've had over previous months, but really try and pull it together to something that is pointy enough to get results in this next budget cycle, but I think also captures the ambition and the boldness, that Pat described. Something along the lines of, a broad, healthy mind mission, if you will, but then something that can really put a little bit of pressure on the federal government for the next budget cycle to do something about it, to get that first building block in place, while a sort of simple, quantifiable doubling or uplift in workforce we know is not enough. But it feels like, what I've heard here is with some refinement and some qualifications there, emphasising access, emphasising equity, something around the workforce, I think, is quite an exciting building block and something that I think Australians for Mental Health can drive. And we also want to do it in a way that, brings the voice of lived experience along with us. We want to do this in a way that really galvanizes that voice. So, but I think it's been a great conversation today, and thanks again, Mark, for hosting us.
Good, and thanks for coming to the university. I think of those in the room, there will be refreshments, I think, outside. But thanks for all being part of it today.
Thanks everybody.
Thanks, everyone. See you. That was great.
That's what you got 90 bucks.
So what do you reckon? So we got it?
Yeah, we got it. It's in the wrap. I think there was a brand at Austin. No, we got it.